Good evening, colleagues. Thank you so much for attending this very important SAMEC NICD webinar on malaria management. I know we've got competition tonight with the SONA report, but let's hope that we all remember that malaria and its management is a critical, important topic. One, I believe, is receiving too little attention in the current environment as dominated by COVID-19 debate. We all know that other illnesses and diseases have not abated because of COVID-19, and there is a need to continue to discuss these issues, lest we forget about them, or rather, lest they be forgotten. If you have already done so, a bit of house rules, please ensure you are on mute. Please reserve all your questions for our question and answer session, which will be held after the last guest speaker has spoken. Also, please, if you are not yet a SAMEC member, I'd like to direct you to the SAMEC website, samedical.org, where you will find more information on membership and amazing benefits of belonging to our association, focused on promoting and protecting your rights as a doctor, and which offer you regular, important information on running and managing your practices. I would like, with these short introductory remarks, I would like to introduce our first guest for tonight. I want to remind you that today's webinar is impressive, and our speakers have insight into this topic. I know their insight and their remarks and guidance tonight will be of great value to everyone attending. Our first speaker tonight is the lovely Ms. Shandukani of the Department of Health. She leads the National Malaria Control Program, a medical scientist by profession. She obtained a Master's of Public qualification from the University of Pretoria in 2016. And tonight she will offer to lead us into our topic by discussing the number of cases of malaria deaths in 2021-2022 season, as well as provide us with malaria risk for South Africa. Ms. Shandukani will also talk about ongoing strategies and interventions regarding malaria elimination. With this few words, over to you, Ms. Shandukani. The floor is yours. Thanks.
Thank you so much. I'm just trying to find my screen. Sorry about that. Okay. Thank you so much, and thank you for the invite to come and represent the National Department of Health on this webinar. I know that my time is limited, but we thought it would be prudent for us to just give you an update of where we are in malaria and what our goals. Just to start off is just to define where we are moving towards as a program, as the National Malaria Program. We are aiming to have malaria elimination interrupted in South Africa by the year 2023. That means that we want to eliminate malaria within our borders. We know that we don't have control of much of outside our border, but we do work with them. What that means is the locally transmitted malaria we need to have eliminated by the year 2023 with the help of doctors and many other stakeholders that are assisting with that. And the next step, according to WHO, would be certification of malaria elimination in South Africa. That will mean that we no longer have local malaria transmission and all human parasites have been eliminated in South Africa. And that's our bigger goal of achieving elimination for South Africa. So just to give you a glimpse of what's going on in South Africa in terms of the numbers, as the speaker said, I need to just address you where we are. You would look on the black and white map, which was our risk map previously. I think this was even before my time, where even the naming you can see. But moving forward, where we are right now, you would know that the risk of malaria has reduced considerably, and it's only located in the eastern and the northeastern part of South Africa, which is mostly in Limpopo, Mpumalanga, and KZN. And those are our 3 endemic provinces that we mostly have malaria affecting us. But however, if you are looking through our neighboring countries and the numbers that they report there, you would know that our incidence of malaria is very low. But just for you to appreciate and to also note is that for any doctor that's located in Limpopo, Mpumalanga, and KZN, you would need to be vigilant in regards to patients that you might encounter, and ensure that you are giving them proper treatment according to the risk map, and also give them guidance in relation to malaria transmission zones. So coming into the numbers, I thought it would be good for us just to show you a trend of malaria over a few number of years, not to only focus on 2020, 2021 season. Malaria is a seasonal disease which normally happens, or you get it around September until February, where that's when it will be heightened, and most of the activities of malaria are employed around then. During the winter months, we don't really have much malaria, but we do get reports of that. But for this webinar, I think I will focus mostly on the deaths. You will see that though the number of cases are reducing, and also for the 2020-2021 season, you will see that we did have an increase in the number of deaths that were reported as compared to the previous season of 2019-2020. What went wrong? What happened in relation to case management? I know that Prof. Blumberg and Dr. Raman are going to expand on that. So we need to heighten, we need to have awareness as doctors, as healthcare workers, to be able to diagnose and also treat correctly, and to avert these deaths that are being reported for the season that I've shown now. And just to also give you some highlights, as South Africa, for us to achieve that elimination goal that I talked about earlier in the first slide, we have a strategic plan that we've developed, and within that strategic plan, we aim to achieve malaria elimination by the year 2023. Though the numbers that you have seen might seem daunting, but remember I said that for local transmission, that's what we are focusing on. And if we are looking at those numbers, it shows that we might and will be able to achieve that goal of malaria elimination. Though COVID also disrupted us in our journey on the gains that we had made thus far, but we are still striving to do that. And one of the key things that we employ, or one of the key main thing that is there in our mission, is to provide effective anti-malaria services. And webinars such as this assist us in terms of doctors and healthcare workers getting awareness in relation to case management and averting the deaths I presented just previously. And to end off, it's just to alert you on the different strategies that we have, or the thematic areas that we employ in the malaria program. As a whole, we have program management, case management, which is one of these ones that we're doing, vector control, advocacy, communication, surveillance, and monitoring and evaluation. And those are just some of the strategies that we employ. And most importantly, we also have cross-border engagements with our neighboring countries in order for us to assist each other in the fight against malaria and elimination. And with that, I would like to thank everybody who joined, and on behalf of the National Department of Health, thank you for the opportunity to present here. Thanks.
Thank you so much, Ms. Shandukani, for this background onto this topic. Without any further ado, I'm going to quickly introduce Prof. Lucille Blumberg. I don't think she needs a lot of introduction. She's very well known. And I just want to say that she was, until September last year, the Deputy Director at the National Institute for Communicable Diseases, NICD. and founding head of the Division of Public Health Surveillance and Response. She's currently a medical consultant to the Division for Outbreak Preparedness and Response, and also consulting for the Center for Emerging Zoonotic and Parasitic Diseases, where her major focus is on malaria, rabies, viral hemorrhagic fevers, and zoonotic disease and travel-related infections. She's also a consultant to Right to Care, and also providing services or delivers services for HIV, TB, sexually transmitted diseases. She's also a member of the South African Malaria Advisory Committee, and it is my great privilege to ask her to go over the virtual podium to speak to all of us on the management of malaria during COVID-19. Prof. Blumberg, what a pleasure. Over to you.
Thanks very much, Dr. Kutsia. Can you all hear me? I can't
Yes.
see any of you. Wonderful. Okay, you'll shout out if something makes me disappear. So thanks very much for this opportunity. We're in the middle of malaria season. We can expect it to continue until at least May. We've had excellent rains. The cases are going to increase. And we have many people who've returned from holidays within our borders, but particularly from Mozambique, who may present with malaria. And we've had many challenges because of the COVID outbreaks. Control has been really difficult, and the teams have had to rethink how they prevent malaria in the malaria areas, spraying teams in particular. But I think the biggest challenge is that the COVID-19, the Omicron wave is overlapping with our malaria season. And there are many similarities in presentation, and cases of malaria are simply being missed. So if anybody presents with fever, flu-like illness, the first consideration, I'm afraid, by the patient and often by the healthcare worker is that they've got COVID. And either they delay going to the health facility because, you know, most COVIDs are in the last wave, this current wave have been mild. And I think people are just not aware of malaria, which is much more rapidly progressive and very unforgiving. And an extra day of illness can make the difference between uncomplicated malaria, which is easy to treat, and severe malaria, which is much more difficult and may result in death. So we do malaria mortality audits, and in 2021, and in audits of more recent cases, we're finding that patients are presenting late. So instead of on the first day or two of their fever, they're coming, 3, 4, 5, 6, by which time they're much iller. Diagnoses are being missed. They're being called COVID, and tests are being submitted for COVID rather than malaria. There's delayed treatment. And although the statistics don't absolutely reflect the number of deaths, I think we are missing some from malaria. And I think within the excess mortality, I think there are a number of patients who've died of malaria without being diagnosed. And I think the key message tonight is really about health promotion, about information for the communities and for our healthcare workers. Every patient now presenting with fever, flu-like illness must be asked about travel to malaria areas. This is a question we always asked before and we don't anymore. Some patients may tell you, or if they're living in our malaria areas, they have malaria until disproved, and that can only be done through blood tests. And this is irrespective of consideration for COVID-19. I think this is the most important message tonight. Malaria, 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 please, before COVID-19. So malaria mimics many other infectious diseases. And I think before COVID-19, we look back at who died from malaria, they were diagnosed as influenza. But I think COVID-19 has replaced that. And then patients with complicated malaria are often misdiagnosed. Depressed level of consciousness, meningitis, encephalitis Often the patient can't give you a history, and actually they've got cerebral malaria and there's a history of travel. Patients who present with fever and jaundice often get called viral hepatitis, and bloods get sent off for that. But jaundice is an important complication of malaria. So just think about it. If you get exposed to, if you have to manage a patient with fever who's jaundiced. Septicemia and complicated malaria overlap. We don't have a major problem with viral hemorrhagic fevers at the moment, but I remember during Ebola, everyone who traveled in Africa and came home and had a fever got labeled as Ebola, door got shut, and most of them, in fact, all of them were malaria. We didn't have any Ebolas. Lots of ticks around at the moment, but just think of malaria because it's really rapidly progressive. I think the groups, particularly where malaria is missed, are those with other comorbid conditions. You don't think about malaria, and I think we're all kind of fixated on those who've got hypertension and diabetes, but if they get fever now, it must be COVID. But ask them if they've traveled, ask them where they live. And then the very young, where presentation is quite subtle, you get often just fever, not cold shivers, hot sweats, headache. And the elderly, where again, presentation is much more subtle. Nobody thinks about malaria. So what about overlapping symptoms?
Sorry, Lucille,
Yes.
Your presentation is not showing.
Oh, do you want to put it up? Can somebody put it up?
I will put it up on this side.
So I don't know where you lost me. I think let's go back to the 4th slide. I don't know why this happened. Sorry about this. What do you want me to do? See, I knew this would happen. Sorry, everyone.
This is the revenge of the malaria parasite. He's taking his revenge on you.
Oh, no, I haven't traveled.
Your slides are back.
Oh, they're not very clear. Okay, do you want me to,
Yeah.
sorry about this. Do you want me to continue? What do you want me to do?
Continue.
But are they
Please
clear
continue.
enough? Okay.
Yes.
All right. So overlapping symptoms between COVID-19 and malaria. Fever may be present in both, in either. We're not seeing a lot of fever with mild COVID now. Certainly myalgia, quite a lot in COVID, definitely a feature of malaria. Fatigue and headache may be in both or either. Loss of taste and smell, it doesn't seem to be a major issue now with Omicron, but that's definitely not a feature of malaria. But sore throat, cough would really suggest more likely to be Omicron. But definitely overlap, and I don't think one should use the symptoms to make that distinction. So now it doesn't want to move. I think you better, there's definitely a problem. I think put up the slide, that's good. Thanks very much. So think malaria, a high index of suspicion for malaria is absolutely critical. Ask a travel history. People may not tell you they've been anywhere for whatever reason, and ask them where they live. And every person, and here I go again, fever, flu-like illness, where the answer to the travel is yes, or they're resident in one of the malaria areas that Bridget referred to, or they've traveled particularly to Mozambique, is malaria until disproved. They have to have a blood test. And Jaishree is going to talk more about that at the end of my talk. There's an urgency to do it. It's your responsibility to get results. And if it's a blood smear sent to the lab, it should just take a few hours. If it's a rapid test, you will have the result in 30 minutes. And really, all emergency departments in our country should have rapid tests for malaria and training in their use. If the test is negative, it could still be malaria. Don't reach for the COVID test. bring the patient back the next day and repeat the test. You may decide to do COVID at the same time, but it's not the other way around. In too many instances, the COVID test is sent off. Sometimes there's a delay, particularly if it's a more rural area, and only when it's negative do people consider malaria. And that's a problem because malaria is very rapidly progressive. You don't have the luxury of time. Next one. Thank you. Next. So what happens if the result is positive? It's a notifiable disease and treatment should be started immediately. It's important to make the distinction between uncomplicated malaria and complicated malaria, and it's not always easy. Uncomplicated malaria implies generally that the patient has not been having symptoms for more than 3 or 4 days. Once you get to 4 days, you're on a precipice and they're going to crash very quickly. So be very careful, whatever they look like. If there's any jaundice, that's severe malaria. Any disturbance of the mental state, any level of confusion, it's severe malaria. And look at respiratory rates. Something we don't count, any increase in respiratory rate, don't attribute it to fever. It may indicate a metabolic acidosis, which is always an indicator of severe malaria, even in the absence of other signs of complications. The treatment is standard. We absolutely do not use quinine for first-line treatment for uncomplicated malaria. We don't use chloroquine, and we don't use Fansidar anymore. Resistance is at a level that precludes their use. So the treatments are prescribed by the national program. Jaishree runs the resistance monitoring program, so we keep a very careful eye. And the treatment of choice for uncomplicated malaria in all persons is combination, and the combination we use is Coartem. And you may not change or choose what you want. For most patients, it's 6 days, adults 6 doses over 3 days. For persons over 85 kilos, we're looking at a longer course of treatment. The dosages were really prescribed for patients in Southeast Asia who are less than 65 kilos. So that's something that we're probably going to introduce into the program quite soon. Importantly, look at the weight of the patient, and there are charts for adults over 60 kilos. It's 24 tablets over 3 days with a modification possibly for weights over 85 kilos. The drugs must be taken with something fatty, otherwise you will not get optimum absorption. And this could be a sandwich with margarine or butter or some full cream milk. If you don't support this or suggest it, we have seen treatment failures. Temperature control is critically important. Use paracetamol. I think Brufen is acceptable, but other non-steroidal anti-inflammatories should not be used. Many patients, even with uncomplicated malaria, have some degree of thrombocytopenia, very common, and it's often a kind of, think about malaria if you see thrombocytopenia and you hadn't, and non-steroidal is not good for that. And some patients are in borderline renal problems, and you don't want to push them on the wrong side. It's not good enough just to make the diagnosis and send them on their way. You need careful follow-up. It's a progressive illness, and they may still complicate. In our malaria elimination areas, selected ones like Northern KZN and some parts of Mpumalanga, we are adding a stat dose of primaquine, low dose, which will act on gametocytes and hopefully have an effect on breaking the cycle of transmission. So that's not routine outside of the areas where this is being used as part of the program. Assess the patient carefully. If there's anything that tells you perhaps things aren't quite what they seem. Patients vomiting excessively, there may be a tinge of jaundice, there's an increase in respiratory rate, they immediately fall into the category of complicated malaria and need to be managed as such. Be careful of pregnant women. They progress very rapidly. There's often a delayed diagnosis because they're misdiagnosed as urinary tract infections very commonly. Be careful of children. They also progress very quickly, and both of these categories may need referral for more careful observation. You can use and should use coartem in both these groups, children and pregnant women, in any trimester of pregnancy, in the case of pregnancy, but they have to be uncomplicated. Otherwise, move them on. Next slide. Next slide. Thank you. So most patients will get better quite quickly. Coartem is very well tolerated. We occasionally see some skin rash, but really it's much, much easier to take than quinine. And if somebody is not better by 72 hours, you need to review them. Did you prescribe coartem? You know, we've had some cases where Paraquin has been prescribed, or Fansidar, and that's not something we would currently use because of resistance. Did they take the drugs? Was there vomiting? Was it the correct dose, or are they somebody over 85 kilos? Most importantly, check that they took it with some fatty food. May not see failures immediately, but a week or two later, they get fever again, and review the diagnosis. How did you make it? Was there an error? This is perhaps a patient from over the border who has just asymptomatic parasitemia and may have something else. You know, they've got reasonable immunity. But mostly patients are better by 72 hours. Don't attribute any failure or poor response to coartem resistance. It's not something we're seeing to any great extent, something we're keeping an eye on. If you get a patient who's not responding, tell us and we will follow up and you know, try and review them in more detail. Next slide, please. Next one, thanks. So this is a typical example where things went wrong. This is a patient who presented to a clinic in northern KwaZulu-Natal, where up to the time of COVID, I think a very different response would have happened. They were very familiar with malaria. So this is an 18-year-old presented with fever, body pains, cold shivers, hot sweats, and it was during one of the COVID waves, and nobody thought malaria. It's a well-known malaria area. So a COVID-19 test was sent off and the patient was sent home. The next day, the patient came back and had respiratory distress and was sent to the hospital and was admitted, in fact, to the COVID ward as a COVID pneumonia. Didn't have x-rays available. I don't think it would have made very much difference, but they actually sent a blood off for a full blood count. And the doctor noted that the platelets were really quite low, which is not something we see even in complicated COVID. So thrombocytopenia is often a clue to malaria. And this prompted a rapid malaria test to be done. It was positive. The patient did not have COVID. He died. And actually, if he'd been treated initially, he'd come perhaps a day earlier, malaria test, as would normally have been done, was done, I think he would have survived. An absolute tragedy. So don't miss malaria in the early stages, and don't confuse respiratory distress, which is an important complication of malaria, with COVID pneumonia. Next slide, please. And platelets, I think, are important to observe. Next one. So these are chest x-rays. Some of them are COVID, and some of them are the ARDS of malaria. And on an x-ray, I think it's very difficult to tell the difference. So just be careful. If you're in a malaria area or you forgot to ask about travel and you see an ARDS, COVID pneumonia, what you think is a COVID pneumonia, just think about your diagnosis. Yes, you can also have COVID and malaria. And today there was an admission to one of the hospitals in Johannesburg, an HIV positive patient who who had non-typhoidal septicemia, had COVID, and they noticed very low platelets, which I think, you know, most people would have attributed to probably the septicemia. They did a malaria test and it was positive. Patients confused, so we don't know anything about travel, but at this time of the year, please think malaria. Next slide, please. Okay, so it's a bit of a busy slide, but you can get, just to note that you can get shortness of breath, increased respiratory rate in both COVID from pneumonia or ARDS. You can certainly get an increased respiratory rate in malaria if there's an ARDS, and particularly if there's metabolic acidosis. Jaundice is not a common feature of COVID, but is an important feature in severe malaria. Thrombocytopenia is almost universal, very common feature of even uncomplicated malaria, and is invariable in moderate or severe malaria. So just notice that platelet count in admitted patients. And then I think I've mentioned quite a lot is that respiratory distress, changes on the X-ray of ARDS or pneumonia. Yeah, it's not always COVID, it may well be malaria, and I think a number are slipping through. Next one. So how do we treat or what do we look for in severe malaria? I think we're all familiar with many of the clinical features. Remember that it's a multi-system disease. I think most people recognize cerebral malaria as the major sign, but in fact, any system can be involved. Get severe anemia, you can get early renal failure, you can get a later ARDS, and jaundice. If the patient is jaundiced and they have malaria, they are immediately in the category of severe malaria. Be very careful. Don't label them and do hepatitis tests. Next one. So we have a patient now who's got any feature of severe malaria. How do we treat them? The treatment of choice is artesunate. The trade name is Garson. It's registered. It's available. We should not be using quinine, and we need to start the treatment in the emergency department. We've looked at patients who've died from malaria. Often the diagnosis was made in the emergency department, and by the time they're treated in the ward, it's sometimes 12 to 24 hours later. So if you work in a hospital, ensure that the first dose, the diagnosis is made in the emergency unit, have rapid tests, know how to use them, and start the dose there and then. It's according to weight, there's more than 20 kilos, 2.4 milligrams per kilo. If you decide to start artesunate, and I think there should be a low threshold now for malaria, it's 3 doses minimum. Then reassess the patient. If they're much better, they're taking orally, you can change now to coartem, and it must be a full course. You know, they need combination therapy. If you don't give them those 3 days, they're going to be back in 2 or 3 weeks' time. If they are not better, you can continue a daily dose of artesunate until you are happy with the patient, and then they still need a full course of coartem. Next slide. So what are the advantages? Next slide, please. Artesunate versus quinine, we should not be using quinine anymore. It has major disadvantages. Artesunate is very rapidly acting. It acts on all stages of the parasite, so it actually stops the sequestration in the blood vessels. You don't get the hypoglycemia, which is a major problem with quinine. You don't get cardiotoxicity. Don't need to change the dose in renal failure. It's really easy to give. A little bit complicated to dilute, but it's given over a few minutes. Quinine, you have to dilute in lots of fluid, given over 4 hours. And if you walk around a malaria ward or a busy hospital ward, you know, it's not possible for the nurses to manage it appropriately. And so some people say it's more costly, but it's actually cost effective and it saves lives. You can use it at any age, any weight, and we are now using it as the treatment of choice in any trimester of pregnancy where there are indications of severe malaria. So artesunate, if your hospital has got quinine, you need to get artesunate. Many doctors say they're comfortable with quinine, but if you look at this, because they've been using it for years, if you look at the outcomes of patients who've been treated with artesunate, you save lives. Next one, I think we're almost done. Next. So just a couple of pointers about managing severe malaria. Fluids are critically important. Malaria patients get overhydrated, they develop an ARDS very quickly, run them fairly dry. You know, renal failure is a complication, but is much more easily managed than ARDS. Carefully monitor the urine and creatinine, get the results when you send them off to the lab, don't wait over the weekend, and importantly, watch the urine output. You know, we prescribe drugs in dosages and intervals, but we very rarely prescribe fluids properly. And I think no adult should have more than 2 liters a day. And you may have to cut back on that in patients with malaria and renal failure, otherwise they will get an ARDS. And early dialysis. Children with severe malaria often have secondary bacterial infections, so they may, I think, benefit from an antibiotic. Hypoglycemia is important in severe malaria in all cases. Monitor. Don't use steroids. You know, we've been using lots for COVID. May need a transfusion in selected patients, and be careful of overloading them. Next one, and I think it is the last slide, and reassess them at least twice daily. Don't leave them over the weekend. So I think we've said quite a lot about pregnancy, same treatment, artesunate for complicated malaria, but I think the most important is missing the diagnosis. Next one, ARDS, hypoglycemia, anemia, very common. And then last slide, thank you. Oh, it's the second last one. So this is the time of the year when the mosquitoes travel, and occasionally they're infected. They hop on a taxi, into a car, into a suitcase, and then they are transported to Johannesburg or Pretoria. And when they get there, they're really hungry if they've survived the journey, and they will bite people. So we do see, you know, a dozen or so what we call taxi or Odyssean malaria, people who haven't traveled because of these traveling mosquitoes. They're rare, but they've got a high mortality because of the absence of travel. So any unexplained fever, patients getting sicker, they're jaundiced, their mental state's down, or there's no reason for low platelets. Think about malaria. And the labs often pick these up. They see a low platelet count in a febrile patient, they look at a peripheral smear, and we give gold stars to them if they identify these unusual cases. Next one. Next. What can we expect for the season? We don't know. There's been lots of rain. In 2017, we had floods. We had a major malaria outbreak. We have a similar climatic conditions this year. So we need to prepare for a busy malaria season. Last slide, finally. Thank you. Next one. So key messages: fever, flu-like illness, ask about travel, ask where someone lives. The answer is malaria area. Test for malaria urgently, get the results. Don't reach for the COVID test first, and then ensure you assess the patients properly, use the correct dose, and carefully followed up. And I think if we follow the rules, nobody should die of malaria in 2022. Thank you very much.
Wow, Lucille, thank you so much. This was excellent. I think a lot of us has been taken back to the years when we studied and learned about malaria. And those of you that are currently practicing in a malaria area, it is extremely important to know the treatment. thank you so much, Lucille, for this. It was great. And I think it was in the nice thing of your presentation, it was short and it was down to the basics, and it's very clear what to do. So thank you again for this.
And apologies for the IT on my part. I always get it wrong.
Well, we will not judge you, because tomorrow it might be our turn. So I would like to introduce our last speaker for tonight. This is Dr. Jaishree Raman, who will talk to us about the do's and the don'ts of rapid malaria tests. Dr. Raman is a molecular biologist by training, with a strong interest in malaria and public health. Currently heads the lab for anti-malaria resistance monitoring and malaria operational research. And the abbreviation is a very interesting one, ARM-MORE. So very, very interesting at NICD. And their ultimate aim is assisting South Africa and Africa to eliminate malaria. And to this end, I think it's important to notice that the ARM-MORE hosts the South African National Surveillance Program for anti-malaria drug and diagnostic resistance monitoring. It's also in partnership with collaborators from other malaria endemic countries and research organizations, including universities of Cape Town, Pretoria, Namibia, California, San Francisco. And I need to say that Dr. Raman's lab is currently investigating novel techniques and technologies aimed at improving malaria case detection and treatment practices. Thank you for joining us tonight, Dr. Raman. I think we would love to hear all the don'ts and and what you need to do, especially for us that doesn't see malaria that often. And I think it is extremely important that we also understand the rapid testings of malaria out there. Thank you. Over to you, Dr.
Thank you very much. It's always daunting to follow Lucille, but I'm going to try my best. And as Lucille has pointed out, it is really important to be able to treat malaria quite quickly, but to be able to treat them, you need to diagnose them. And today I'm just going to go through very quickly some do's and don'ts about using the malaria rapid diagnostic tests. They have just really revolutionized how we can detect malaria, because they're a point of care diagnostic tool. But there are some basic errors that some people are making, and I just want to highlight that to make sure that we effectively can detect malaria cases early and ensure that they're treated so we don't have any deaths in South Africa. So the malaria diagnostic tests that are out on the market at the moment actually detect a malaria, something that is produced by the malaria parasite, so they're antigen-based. The three most common proteins are the histidine-rich protein, which is a falciparum-specific RDT, and there's another two that they can also detect, which is lactose dehydrogenase or aldolase, which is much less used. But in South Africa, because we have mainly falciparum infections in the public sector, we tend to use a falciparum-specific rapid diagnostic test, which detects the HRP2 or the histidine-rich protein. And it is the histidine protein is produced in large amounts, so it makes the RDT very sensitive compared to the lactose dehydrogenase RDT, which is not species-specific and is produced in much lower quantities. And though the lactose dehydrogenase RDTs are known as pan-kits, which means they can pick up falciparum and non-falciparum infections, you also need an additional test to find out what non-falciparum infection it is. But as I've stated, in South Africa, because we have so many falciparum infections, we use a HRP2-based RDT. And I'm going to focus specifically on the first response RDT, which is the one that is used in the public sector. There might be different RDTs that are used. For example, the NHLS labs use an ICT RDT, but they have the very similar ideas and they both are falciparum specific. But I just want to point out a few things. On the box, it gives you a bit of information. It tells you the temperature range, which you can use the test. but the test really should be stored at room temperature and not at very high and very cold temperatures. Obviously, very important to ensure that the expiry date is valid. Important, and it's something that we pick up particularly in hospitals where they open a number of boxes and they mix reagents between boxes. It's actually something that's not recommended. So open one box, use all the reagents from one box, and then move on to the next box. Don't open multiple boxes and move the reagents between them. The next thing is also very important with your RDTs, and particularly with any type of RDTs, is to keep your box flat as possible. And the reason I'm going to, why we recommend that is I'm going to show you what an RDT looks like, and you're going to understand it a little bit more. So on your left-hand side, you're going to see what an RDT looks like in the malaria RDT. It's causing a little bit of confusion at the moment in the public center because First Response also provides the rapid diagnostic test that is used for HIV testing. And in contrast to the one that is used for HIV testing, the First Response RDT for malaria has two wells. You have one well that is for the lysis buffer and one well that is for the blood one. So you've got to put them in two separate wells, whereas when you have the HIV one, you put the lysis buffer and your blood in the one well. And for the malaria one, it is really important that you put the blood in the blood well, and the lysis buffer has a chance to move over the blood to ensure that it can break all the red blood cells. You put them together at the same time, you've got less lysing of blood and a reduced chance of picking up malaria infections. On the right-hand side, I've got a picture of what the rapid diagnostic test looks like inside, and it's really just a piece of filter paper in which antibodies are specifically made to the malaria antigens are actually stuck on the filter paper. You can't see them, but they are stuck on them with glue. And if you imagine that you have a picture stuck on your wall with Prest-it, as it gets very hot, the Prest-it is going to slip as well are your antigens or your antibodies are going to move. So that's why we recommend if you're going to store your RDTs, you store them in a cool place and you store them flat so that you don't have your antibodies moving, and it makes sure that the test works correctly. So just a few recommendations when using your rapid diagnostic test. These are just our recommendations. Obviously, you can modify them to suit you. We definitely recommend when using your rapid diagnostic test for malaria, you choose either your index, middle, or ring finger, and you take it from the non-dominant hand. And we've suggested the non-dominant hand so that no one can complain that they can't go back to work after having their finger pricked. We also recommend that if you are going to prick the finger, you prick off center because it's slightly less painful and the skin is much thinner. So it's much easier to prick the finger. And we also recommend that you wipe the first blood drop away because there's a chance of contamination possibly, or some alcohol that is left from cleaning the finger. And also there's a slightly reduced chance of picking up parasites in the first blood drop. So you've got a better chance in the second or subsequent blood spots. When you use, and this is specifically for the First Response RDT, here it is very, very specific how much you add. You only add 5 microliters of blood, and it's just what goes into the cup. In terms of here, it's more is not better. This kit is made to take 5 microliters of blood and 2 drops of buffer. Do not add more. I've seen people squeeze it like you're putting ketchup or tomato sauce on your burger. It's not that way. It's just 2 drops of blood 2 drops of buffer that needs to go on there. And you need to read the test at 20 minutes, but not after 30 minutes. Do not wait. Recently, we heard a doctor suggesting that for low parasitemias, they like to leave it for an hour because they think the test will be much better. These tests are designed to be read at 20 minutes, so read it at 20 minutes, but not longer than 30 minutes. Some indication of what happens if you do something incorrect. If you add too much blood, you get the blood proteins not being broken up properly. They move through the window and you get clogging of the window and you can't see your test line. The middle picture shows you when you get the blood and buffer added to the buffer well, when people are confusing the malaria RDT with the HIV RDT, you tend to get the blood not being broken up properly and you've got an increased risk of getting a false negative result. If you read your result for 20 minutes or before 30 minutes, you've got an increased chance of getting an incorrect result, particularly when it's low parasitemias, because they tend to come up positive around about 20 minutes. You add too much buffer, you've got an increased chance of getting a false negative result because the buffer moves over the test much quickly. too quickly, you don't get a chance for the antibodies to bind to the antigens, so you don't get any test line forming. Just to give you a little bit of an indication, a problem that has come up, we haven't had it in South Africa, but it is something that you need to bear in mind. Parasites are becoming resistant to the HRP2-based RDTs in terms of there's a deletion. So they evade detection by the rapid diagnostic tests that are HRP2-based. It is not present in Southern Africa, so anyone from Southern African region can be tested very successfully using an HRP2 RDT. But if people are going to be coming from Rwanda, Ethiopia, or Eritrea, where these mutations are very prevalent, you have to take that into consideration. You probably are going to have to use a lactose dehydrogenase or LDH-based RDT, or do a blood smear to confirm a malaria infection, because they are going to come up malaria negative if you use an HRP2-based RDT. The other thing with using an HRP2-based rapid diagnostic test, it can only be used for initial diagnosis. The HRP2 protein, while produced in large quantities, which makes the RDT very sensitive, it also stays in circulation long after the infection has cleared. And so it's about 4 to 6 weeks. So if a patient comes back after 3 weeks and says they haven't cleared, they're still feeling sick, you cannot use a rapid diagnostic test to test them because they're going to come up positive. So you have to use microscopy or PCR to confirm an infection. And that's all I have to say. Thank you very much.
Sure. This is, again, Dr. Raman, very insightful. This is the first time that I see a rapid test. And I was wondering about it. I did read up about it, and I saw this 3 types, and I decided, no, I don't know which one is the best. And let me rather not order them, but we also don't see a lot of malaria where I'm practicing. But thank you so much for this. This is so insightful. And I hope my colleagues also learn something from these rapid PCR testing that's available in South Africa. So I'm going to ask Dr. my vice chair, Dr. Mbavhelo Muzukwa, and I will plan.
Thank you so much, Dr. Angelique, for those introduction of speakers, and thank you so much also to the last speaker. I will now open the floor to questions. Please, you can put your questions on the Q&A session there. And I think let's start rather on the first question that we can see. There's a question that came up. It says, will you be able to watch this live stream again? Will we be able to watch this live stream again? And I hope the answer is, oh yes, there's an answer that has been given already there by our management team. So I believe that that's the case. We need to move on. The other question was that if you are relocating to a malaria area from a non-malaria area, what type of prophylaxis should be taken? What dosage, what intervals, and for how long? If we can have one of the panelists, perhaps Prof. Blumberg answering that question for us.
Okay, so we didn't discuss prophylaxis tonight. I think it's a subject on its own. In our malaria areas, we actually don't recommend prophylaxis for people living there. That's not the group we're talking about. We do indoor residual spraying with long-acting insecticides, and we prescribe early treatment, so high awareness. People going on holidays or moving to a malaria area will depend on the risk of malaria in that area, the season, and where they're going to live. So if somebody from South Africa is going to live in Malawi or Mozambique, for a period to make their house mosquito-proof, to ensure that they access early treatment, and they may want to take prophylaxis for the high season. We really have only two options, doxycycline, atovaquone proguanil. I'll refer you to the guidelines for dosage. There are recommendations for how long you can take these, but don't forget about personal protection against mosquito bites. So ensuring your house is mosquito-proof with screens, air conditioning or fans, the use of insect repellents, particularly with those containing DEET to exposed areas when the mosquitoes are active, which is after sunset. So that's a summary of prophylaxis and prevention. And early treatment always. We need to tell anybody traveling, anybody moving about the symptoms of malaria and the urgency with which they need to seek treatment. I think we need to give patient power a bigger focus.
Thank you very much, Prof. Blumberg. If we could just go to the next question. I'm not sure if this was directed to you, Prof. Blumberg. It says, what can you tell us about the Ebola cases in the UK? I'm not sure if it's...
So I can tell you. So
thank you so much.
It's not Ebola, it's Lassa fever from West Africa, from Nigeria. It's a family. I believe they're stable. Lassa is exported on occasion from endemic areas. It's the season now for Lassa, particularly in Nigeria and surrounding countries. The UK has had previous cases. They have an excellent lab, they have excellent facilities for management, and hopefully they will do well. But, you know, think malaria before a VHF, but these are confirmed Lassa cases.
Thank you so much. And why is Brufen, okay for temperature control, but not the other NSAIDs?
Yeah, so that's an interesting question. I think paracetamol is the best. I was challenged before on Brufen. There are quite a lot of studies to show that it's safe. My first choice would be paracetamol. I think the others perhaps would have more effect on renal function and perhaps reducing platelet counts and bleeding. So I think there's less good studies, less studies to support the use of non-steroidals. So I think keep them away, use paracetamol, and if you have to, use Brufen.
Thank you very much.
We know all the answers on that yet.
Thank you very much. There was a question on Texi malaria. I think you did explain that in your presentation. The other question also again, there was a question on that, but the other question is there a place for doxycycline in relapsing falciparum malaria uncomplicated?
No, there's no place for doxycycline in treatment. We used to use it when we used quinine. We used to follow up with doxycycline. It's a very weak anti-malarial and should not be used. It is part of our, prophylaxis for persons over 8 years of age, but it's not used for treatment. If persons are treated for malaria and a week or 2 or 3 weeks later they get malaria, you know, review the diagnosis, see whether they are perhaps larger and their dose wasn't adequate of coartem, or they didn't take it with food. So we see what we call as a recrudescence. You know, there's a couple of parasites and they come back. We also see that if people got artesunate and didn't follow up with coartem, they got single drug therapy, and then you can have a true relapse. We know that you can get falciparum plus Vivax or Avali, and you need an extra drug to get rid of the hypnozoite stage of Vivax or Avali, and that would be primaquine. So you treat them initially exactly as you would others, artesunate or coartem. Mostly they're uncomplicated, but if they are confirmed on a microscopy, you need to follow them up with primaquine, not easy to access, and you have to do a G6PD level first. So doxycycline has no place in the treatment of malaria.
so much, Prof. The dosage of Coartem in children?
So I'll refer you to a dosage chart. It's based on age or weight. And I think those are readily available. Did give you some websites. The NICD website has the National Treatment Guidelines and the SAMEC, which is the travel medicine website, I think has got very good information on different dosages. And you must consider dose and weight. But for adults, generally 24 tablets over 3 days. More if you're bigger.
Thank you, Prof. Is the malaria vaccine still at experimental stage?
So there's been lots of work on the malaria vaccines. I think we finally have one that's, I think is showing great promise. It's only for children, and it's for children living in high-risk areas. So it's not for travelers, it's not for adults. It's now been registered and is being used as part of malaria control in hyperendemic areas. So Kenya, Malawi, Ghana, I'm sure there's one other place, but it's not something that we would use in South Africa. It's only for young children, it's 4 doses, and it's really has a place in high transmission areas, and we're not one of those. And it's part of the program, probably about a 30% efficacy in terms of preventing severe malaria. So perhaps there'll be new generation ones, but this is the best one we've had after many years of trying.
Please, Prof, comment on the management of mixed or co-infection with falciparum and non-falciparum malaria. Yeah,
so we do see mixed infections. I think Jaishree explained about some of the problems of the rapid tests. They don't perform as well for Vivax or Evali. They're dependent on how many parasites there are. So the sensitivity is quite poor, and the reading of these in those pan tests is not done very well. And I think the detection of non-falciparums is quite difficult even on smears. So we do get mixed infections. We treat them exactly the same. The initial treatment is Coartem for uncomplicated, artesunate for complicated, and if there is Vivax or Evali, we follow up with Primaquine. You sometimes see patients where they only see falciparum when they're admitted, and then a couple of weeks later they come back and suddenly the others pop up. So, the one just sort of overwhelm the others, but we do get mixed infections. Acute, treat the same. Don't use chloroquine for anything. Okay, there's many non-falciparums that are misdiagnosed and misidentified. Jaishree, do you want to say anything more about that?
Just to say, you're completely right. We tend to have very few infections within the area. It's really people that have traveled from outside of the country to Asia or North Africa. So we tend not to have very many mixed infections in the country, and they are very difficult to detect using the pan-specific RDTs. So if you do suspect a non-falciparum infection, it's much better to do a PCR or a smear. Over.
Yeah, and then just to mention that prophylactic drugs like Tovacone, Proguanil, or doxycycline taken in travelers, who are going to malaria areas will not prevent Vivax or Evali relapses.
Thank you very much, Prof, and your response to those questions. It says, Prof, it looks like the dose of artesunate is inversely related to the weight. A person weighing more than 20 kgs receives a smaller dose, whereas the one who weighs less than 20 receives a higher dose. Could you expand on that?
You're absolutely right, and it's important that that's noted. It's probably to do with the volume of distribution. I'm not a pharmacologist. We need Professor Barnes here for that. But it's the volume of distribution. It's probably the metabolism. I think those would be the reasons, but important to note the differences. Yeah.
Thank you, Prof. would you come again on the precise dosage for Coartem and artesunate?
So I think we need to refer you to the guidelines for that. For an average adult with uncomplicated malaria, and make sure it's uncomplicated, Coartem would be 4 tablets stat, 4 tablets after 6 or 8 hours, and then 4 tablets twice a day for another 2 days. So that adds up to 24 tablets. If it's person over 80 kilos, we think they probably should have another 2 days of exactly the same dose. 4 tablets in the morning, 4 tablets in the afternoon, and for those 2 days. For children, I'm going to refer you to those tables. I don't think we really have the time to go through each weight group. And then artesunate, I think we've provided the doses. Importantly, anyone who gets artesunate, you must follow up with a full course of Coartem, 3 days. Otherwise, you're just treating them with one drug and there will be a few parasites left over and they'll be back. So make sure.
Okay, thank you so much. I think this question is directed to Ms. Shandukani. Is there a national tender that hospitals can use for ordering the malaria RDT?
Thank you for that. Yes, there is a national tender that's there, and hospitals ascribe to that. You just need to liaise with your pharmacist. They will be able to access it. So all hospitals in South Africa are using the national tender for RDTs, just like the same as for Coartem or any drugs that's available. So there's a tender for that too. Thanks.
Yes. Just to come back to the RDTs, I mean, if you're in a hospital or a setting where there's very good laboratory facilities and you can get a reliable smear back very quickly, there are some advantages. You get a parasitemia, not always well done, but 5% or more, it's usually severe malaria, 1%. Be careful. You need to look very carefully at the patient. You do get speciation. You can monitor the decrease in parasitemia. But I think if you're in an area where access to laboratories is limited and results may be delayed, I think an RDT as an initial test is very important. Let's follow all the rules that Jaishree spoke about.
Maybe whilst you're still there, Prof, is it possible to comment on the cost of RDTs and medical aid reimbursement?
So I don't know if Jaishree can comment or Bridget can comment. We're using a lot of RDTs in our public hospitals. They are the diagnostic of choice in our clinics, where it's really not possible to send a smear away and get it back in time. I think many private practitioners are using RDTs, and I'm not sure about the reimbursement. But they should be, because it's really a very reliable, quick test if it's done properly. I don't know if the others can weigh in, maybe somebody online. I don't know. They should. Send them to me if they're not.
Okay. I think this one is directed to Dr. Raman. If there is no pipette, is 1 drop of blood equivalent to 5 microliters?
Yeah, that was a very interesting question. So it's 1 small drop. Yes, it's not, it's not a huge big drop, but there should be a pipette, because the pipettes come with the kit. But if you don't have a kit, then 1 small drop would definitely come up to 5 microliters.
Thank you very much, Dr. Raman. The next question is, what about the malaria vaccine that is being rolled out in certain countries in Africa? I think you've answered this, Prof.
I've done that, yes.
Yes.
Not for us.
Okay. Yeah, and also you've commented on the dosage of Coartem. Can we move on to, is it correct that artesunate dosage is higher in lighter patients? You've already answered that question as well.
I think we've answered that. Just to come back to the Karate, just remember to inform your patients of the need to take it with fatty food. Many patients with malaria are anorexic. Some don't have access easily to fatty food, but it's critically important. And it could be a sandwich with margarine. If they vomit the first dose, they need a repeat. And if they continue to vomit, they need referral to hospital for treatment. And children often vomit, even with uncomplicated malaria. So they will need referral.
Okay, thank you very much. Can we initiate malaria treatment, particularly if you suspect the severe form, without a positive malaria test, rapid test?
Yeah, so that's a really important question. There's a big differential diagnosis of acute febrile illness, malaria versus other. In most cases of severe malaria, you will get a positive smear or a rapid test. If you're in an area where you don't have access to any diagnostic and you highly suspect malaria and the patient is really ill, start malaria treatment, but have an open mind. You know, once we start treatment, we close our minds to anything else. And so there's a broad differential diagnosis, anything from, you know, hepatitis to, dare I say, Ebola or sleeping sickness. That's often the common one, from Malawi or Zambia, but not from here. So just be very careful. Don't close your mind. You may be missing something else.
Thank you very much. Prof, there's a question again on COVID-19 and malaria co-infection plus steroids.
That's a very good one. So we do see COVID-19 in patients with malaria. You know, they live in a malaria area, there's COVID around. Malaria is obviously the most important one to detect because it requires very urgent treatment. If they happen to test also, you know, you have to have an open mind to COVID. And especially in patients who've got an ARDS or pneumonia, I think it's reasonable to do an additional test for COVID. If it is positive, I think it would be important to use steroids. They're highly effective for COVID pneumonia. They're not really recommended for malaria, but we're managing a tricky situation here. But make sure your results are correct. Okay.
So much. I'm sure this question, the next question will be also maybe Ms. Shandukani will be needed. It says most of Northwest cases are from Mozambique. Is there something that Port Health can do to test people as they enter the country? I know, of course, about illegal immigrants.
Thank you for that question. Yes, we are currently in how can I say this? But then we are trying to get approval for all EHPs to test and treat. So what we've done currently is to have it for the malaria program specific environmental health practitioners so that they can be able to do that. So the next step will definitely be targeting the EHPs by the borders so that they can assist us with that. It is in the pipelines, and we will definitely work on that from the National Department of Health. Thanks.
So just to add to that, if you come through the Mozambique, Northern KwaZulu-Natal border, there's an NGO supported by the province. As you come through the border, before you get into a taxi, you have a malaria test. Many of those persons are asymptomatic because they're Mozambicans who've got some immunity. We don't want those parasites. Our mosquitoes are going to feed on them. It's part of our elimination strategy. They're tested, they're treated, and then they're sent on their way. It's a very effective program, but as Bridget said, we need to expand that.
Okay, thank you so much. There's another question. It says, I practice Bloemfontein and we do see travelers malaria often. Delayed presentation is almost always seen, and I always believe high index of suspicion is indicated. Treatment on basis of suspicion, if that's the case, a state dose, you think?
So absolutely, I agree with high index of suspicion. I really think we should be diagnosing malaria. Our malaria program says you need a parasitological diagnosis. We have effective drugs, but they need to be used on patients with confirmed diagnoses. Otherwise, we're going to be treating many other things. So, you know, if you don't have easy access, patients can't pay for a lab, invest in some rapid tests and, you know, follow Jaishree's rules and do them accurately. I think we really should be testing.
Thank you so much. How do the species-specific RDT differentiate PF from other plasmodia?
Okay, so when you have the pan-specific, which then detects the falciparum or the non-falciparum, so they always have an HRP2 line or a bit of antigens that are going to pick up the falciparum specific, and then they have the lactose dehydrogenase that picks up the non-falciparum. So that's how it tells the difference. So you always have an HRP2 antigen that is based on your RDT that is going to pick up your falciparum part, and then you're going to have the lactose dehydrogenase parts that are there that will pick up the non-falciparum. Hopefully that answers the question.
Thank you so much. Appreciate. I think you've spoken quite a mouthful regarding the malaria vaccination, Prof. There are two questions. I think you've already answered those questions. Can we go to this question? What is the impact of paracetamol on parasites clearance? Prof?
Nothing really. Yeah, I'm unmuted now. It's important to reduce the temperature. You know, fever makes patients uncomfortable. And in children, you know, with high fever, they often vomit, and obviously they could have convulsions. So paracetamol is really for symptom relief. And I think it's an important part of supportive treatment.
Thank you so much. There's another question on malaria vaccine that you have already presented on the update. And the dosage, you spoke about that. And there's another one, let me see. Regarding the follow-up, recently had a child admitted, started treatment as severe malaria, but then determined not to be severe. Had a CRP of 160, slight jaundice with TSB of 34 only, platelets 81, HB8 after 2 doses quinine, changed to Coartem and not sure if completed a full course of it, sent home with no follow-up, and of note had frank hematuria, that is red urine, not black, and 4+ blood on dipsticks, but no renal impairment. Should we call back, and what should we be looking for? Are there prolonged complications or will it resolve?
So many things to discuss there. Why are you using quinine? You really should be using artesunate, highly effective, saves lives. And as I showed you, all the major advantages with versus quinine, we're going to be withdrawing quinine from hospitals. So you need to make yourself familiar with artesunate and ensure that your hospital has it. So once you commit to artesunate, and a fairly low threshold if you're concerned about patients. The jaundice is worrying me. That would indicate severe malaria. A tinge of jaundice is enough. The platelets are variable. You know, they are reduced in malaria. They don't always indicate severe malaria. I think below 60,000, one would start to be a little bit concerned. So I think the patient should have had 24 hours of artesunate followed by Coartem. You know, I think you need to follow up the patient now, get them back. It's impossible to know what's happened to them. Renal failure, if it's managed properly, is reversible. And most patients will get better. Cerebral malaria, it's variable, and the outcomes, you know, are very variable. With artesunate, you may have a delayed hemolysis. So keep an eye on hemoglobins. But I think you need to change to artesunate from tomorrow. from tonight.
Thank you very much. Thank you very much, Prof. Malaria and sickle cell anemia, any word in update?
Yeah, it's a discussion on its own. So we do have patients with sickle cell from other countries. Some of them are heterozygote, some of them are homozygote. It's not complete protection against malaria. And in fact, malaria in the heterozygote is the commonest cause of, I sometimes get this wrong, of a hemolytic crisis. So it's an important combination to note. I'm happy to refer you to some specific guidelines to follow up. I think it's a bit much for us to discuss tonight, but very important to raise that. And they certainly need prophylaxis when they go home. It's not a complete protection against malaria.
Thank you, Prof. I sometimes give my patients a script for Coartem and tell them to take it until they have 2 consecutive negative tests. Your comment, Prof?
No. So if you have a positive result and they're uncomplicated, start Coartem, give the full course. You can, and clinically they should respond. There is no reason to follow up with laboratory tests in uncomplicated malaria in patients who've taken their treatment properly and symptoms have resolved within 3 or 4 days. We don't need to do follow-up tests. And as Jaishree mentioned, the rapid test remains positive for anything up to 6 weeks. And they don't need a smear. If they're remaining symptomatic, they will obviously have to take a smear. Patients in hospital, we would like them to be negative by 7 days. But again, we don't have to, if clinically they're improved, we don't have to religiously follow those smears twice daily. But uncomplicated malaria, unless you're looking at resistance studies, we should not be following up with definitely not rapid tests, and they don't need follow-up. Yeah.
Thank you very much.
Jaishree, would you agree with that?
Absolutely. I mean, there's really no need, and definitely, if the patient is not cured by day 3, or is not feeling well by day 3, then you need to do some investigation. But 2 consecutive tests, it doesn't really make any sense if you're going to use an RDT. So definitely.
But it's a really good question, and I think something that needs to be addressed. Yeah.
Thank you so much, Prof. The next question reads, I had an adolescent patient with complicated malaria, but the pharmacy would not release the artesunate without parental consent. Is this still required? This resulted in unnecessary delays.
No, so it's send me that pharmacist. I will deal with them. The drug is registered. It's no longer Section 21. It does not need patient or parental consent. And since I think it's 4 years now, it has been registered, and it is the treatment of choice for complicated malaria in all patients.
Thank you so much, Prof. I think you've answered the question on prophylaxis. Let's move on to the next question. It says, where is this now? I think the person who's have lost me now. Okay, when would a patient be fit for discharge with severe versus mild malaria, and follow-up suggestions? I think that was the last question.
Yeah, so I think that's really a clinical assessment that we have to deal with many patients. Most patients with mild malaria will start to feel better within 3 or 4 days, and then they could go back to school, they could go back to work, depending on how their clinical situation is. We need to recognize that there may be a degree of fatigue for a little while, but as long as their fever is down, they're feeling very much better, that's a good sign. Patients with severe malaria, I think it's about, when they've had complications that they're resolving. It's really a clinical question based on clinical assessment and your clinical decision.
Thank you so much, Prof. I think we've come to an end of our Q&A session. And thank you to Dr. Kotsie for handling the introduction and the rest. And a special word of thanks to our guest speakers, Ms. Shandukani, Prof. Blumberg, and Dr. Raman, for the wonderful insights you have given us here. We cannot forget that even during a pandemic, there are other medical issues and interventions that require our attention. And I think tonight's presentation have again highlighted the need for vigilance and attention on those illnesses and diseases which are sometimes forgotten. Thank you also to our guests who attended tonight's webinar and to the SAMEC team who made this possible. A last word from my side is to please continue engaging with SAMEC and attending these webinars. We can never stop learning, and these webinars offer a perfect platform to get new and current insights into the important and relevant topics. With that, I formally close tonight's proceedings. But before that, please note that there's a survey that's coming up. It will continue even after I have stopped speaking. Please just fill in those questions and take it from there. Thank you very much. I appreciate your time and all these presentations. I appreciate. Good night.